Good morning, everybody. I am Dr. Anil Srivastav from Gorakhpur. So we are going to discuss about the modalities of refractive surgery, and we'll try to explain that if you have surface ablation and phakic intraocular lens surgery, so these two will make it complete. You don't need to look for flap or lenticule surgery, which is slightly more traumatic than this. So to start with, first we will discuss how to prepare the case, the pre-operative assessment by Dr. Dipesh, and then, so may I invite Dr. Dipesh, and after that I will explain that how refraction itself is very essential, and it is a real foundation to get a good result in any refractive surgery, whether it is IOL surgery or phakic surgery or laser surgery. Unfortunately, reflection is not taught nowadays in residency, so we are fully dependent upon the optometrist. So if we know a little bit, we can refine it. So only that part I will explain, and after that, phakic IOL surgery will be dealt by Dr. Sudhir. I think he is on the way. So let us start. Dr. Dipesh.
Thank you, sir. Thank you for including me in this IC. So when it comes to refractive surgery, I think the main success lies in precise preoperative measurements. It's very important to eliminate at-risk cases and choose the right procedure for the patient. So refractive surgeries can be broadly based on cornea-based or lenticular-based. Preoperative evaluation, the list is exhaustive. I'll try to keep it brief. Age, of course, as we all know, should be more than 20 years. Good refraction, very important, will be discussed in the next topic. A thorough slit lamp examination to rule out any pre-existing disease like glaucoma, subtle uveitis, MGD, etc. Pupil size should be more than or at less than 6 mm in mesopic condition. Coming to cornea-based procedure, the foremost and the most limiting factor is corneal thickness. Minimal residual stromal bed thickness should be 250 to 270 microns. Post-operative corneal thickness should be more than 410 microns to prevent post-operative ectasia. And not only the corneal thickness, but amount of tissue altered is important. So percentage tissue altered, that is PTA, if it is more than 40%, chances of ectasia are very high. Corneal biomechanics have shown us that the anterior stroma is more stronger than the posterior one. Unfortunately, we are ablating this anterior stroma. So what we are doing is, we are altering the most strongest part of stroma. Randleman's scoring system has shown that thin cornea itself is a risk factor. So if we have a young patient whose thickness is less than 500 microns, then these cases are at high risk. Coming to corneal topography, we all know tomography is better than topography. It gives us true anterior and posterior elevations. The most important thing that we have to rule out is keratoconus. I'll just enumerate some important points that we should see in corneal topography or tomography. The cornea should not be too flat or too steep. Anything less than 35 or more than 49 diopters will lead to a lot of glare, halos, and poor night vision. Minimum corneal thickness should be 500 for LASIK, and in PRK we can be a bit liberal, around 470 is also good. C for difference in anterior, superior or inferior corneal curvature. If the second point on corneal curvature shows steepening by more than 1.5 diopters, it is risk factor for keratoconus. The skewed radial axis should not be more than 21 degrees. We should look for any significant anterior posterior elevations. Any anterior elevation more than 12 microns or posterior elevation more than 17 microns is a red flag sign. Probably ICL is better in these patients. Pentacam also gives us a very comprehensive Berlin-Ambrosio map. This is a very good map, good for beginners, easy to understand. If the patient's line is outside reference limit, this indicates a bad cornea, it's a bad score, and these patients should be avoided for corneal procedures. ICL may be better. Corneal epithelial mapping is a newer examination, emerging one. It has been seen that epithelium is not uniform. When we have stromal thinning, the epithelium slowly gets thickened. So it compensates for that thinning, and corneal topography may give misleading results in these cases. In keratoconus, corneal epithelial thickness shows the typical donut pattern where there is central thinning surrounded by annular thickening. When we do PRK, corneal epithelial thickness is very important because machine takes the epithelium as 55 microns, but it may not be same in all the patient. So if we measure the epithelium, it can help us to eliminate subtle over and under correction postoperatively. When we plan for ICL, two most important measurements are anterior chamber depth and white to white. AC depth should be more than 2.8 mm for myopia and more than 3 mm for hyperopia. It has to be kept in mind that ACD is from endothelium to anterior lens capsule. So if we measure with ultrasound or IOL master, they will give us total ACD. So we have to deduct the corneal thickness, whereas Pentacam and ASOCT, they directly give us aqueous depth that is from endothelium. Not only the central AC depth, the peripheral part, that is the angle, is also important. If the patient's angle is less than 30 degrees, it is a risk factor for angle closure glaucoma. When we place ICL, the anterior chamber depth decreases by 12 to 16%. Coming to white measurement, we all know that ICL is placed in sulcus. But measuring sulcus to sulcus distance is very difficult, it's very impractical. So what we do is we take white to white as a surrogate measurement for sulcus. Various machines can help us taking white to white measurement, calipers, IOL masters, Pentacam, Opscan, etc. Studies have shown that IOL master and Pentacam give very consistent result. Whereas in manual caliper measurement, there are a lot of inter-observer variation. But still, most surgeons, I think, believe that digital calipers are the standard, they are the gold standard for measurement. And whenever there is a confusion, we should resort to digital calipers. The problem with digital caliper measurement is we have to take it from the mid-limbus. If there is pterygium or pigmented cornea, it's very difficult to see this landmark. And also in uncooperative patient, it may be difficult to do on slit lamp. We might have to take them to OT, which is basically not very practical in busy OPD. What we would suggest is have at least 2 to 3 machines to measure this. And initially, compare all the measurements from IOL master, Pentacam and manual calipers, and then slowly as we gain confidence, we can shift to these Pentacams and IOL master. Corneal endothelial count should be less than 2000 at any time because the endothelial count decreases with age. Also the hexagonality should be better, it should be more than 50%, anything lesser can lead to corneal decompensation. Tear film evaluation, this is the most commonly missed test. We know that refractive surgery, especially the cornea based surgeries, will lead to dry eye problems. So we have to rule out any pre-existing mild or moderate dry eyes by various tests like Schirmer, Tibert, tear meniscus, etc. It takes a lot of time, so we most of the time miss this test, but nowadays it's very good that we have machines which measure these parameters in the lab, and they give us a very comprehensive report in just one page. Coming to last but not the least, the retinal lesions. So retinal patients, myopia patients may have a lot of retinal problems. We all know it can be myopic CMDM. We have already seen the previous topic. they can have holes, they can have schisis, and the most important thing is in the periphery, where they have lattices with or without holes. Now, this is where the role of multi-specialty comes in. We should always get the fundus checked by a retina specialist, because if there is any holes or lattice degeneration, this can lead to postoperative retinal detachment. And personally, I have operated many cases where patient had gone refractive surgery and then he developed RD. And however, these are very high demanding, high paying patients. So we have to take care and see for any, even if they have a very small lattice, we should go and barrage them. Because the risk of retinal detachment increases with myopia. Patients with more than 6 diopters have almost 22 times more risk for retinal detachment. So it's always good to laser these lesions, wait for 2 to 3 weeks and then proceed for refractive surgery. To summarize, preoperative evaluation is as important as surgical procedure. Proper case selection is the key. Precision is very important in these surgeries. Don't rely on single test. Have at least a lot of machines in your armamentarium. Compare with 2 to 3 machines and then proceed for surgery. And treat the associated lesions like MGD, retinal lattices first, and then go for refractive surgeries. Thank you very much.
So thank you, Dr. Dipesh. And now I invite our Chief Instructor, Dr. A.K. Srivastava sir, to kindly tell us about refinement of refraction is a key success to any refractive surgery. As sir was saying, I think almost all of the ophthalmologists now, no one is doing refraction, and we are totally dependent upon the optometrist. And sometimes this results in a very unfortunate situation in which we cannot neither blame the optometrist nor we can blame ourselves. So it is very important to do a good refraction, and I think Dr. Srivastava is the best person for this. To you, sir.
It's not moving. Yes, sir. Yes, moving. So refraction is the foundation of refractive surgery. I will not discuss about the basic of refraction. I will simply tell that if your best optometrist has given you the refraction, and how to refine that, how to recheck that, how to cross check that. Only that much is very simple, and that can be done simply by using JCC or even without JCC with the 0.5 diopter cylinder, fogging, duochrome, binocular balancing, and utilize the ocular dominance. Sometimes, not always, but sometimes you need cycloplegic refraction just to reaffirm the subjective refraction. It is not necessary that whenever you have done cycloplegic, you have to call them for PMT, post-metastatic test. Only sometimes you need PMT and reschedule the repeat refraction. So, before checking the refinement, you should have UCVA, present glass power, present glass vision, auto-ref reading, retinoscopic reading, and with these sets of data, by trial, your optometrist has already given a power. And now your task is to refine it. Although he has also refined it, we have to train our optometrist to refine it, but we should know how to refine it. So, suppose this is the power given, -1, -0.5, 90, and left eye +2, 1.5, 170, and how to check that this is correct. And it is going to take some time, at least 5 to 10 minutes. See the Jackson cross cylinder, it looks slightly difficult, and as a doctor you might not be in habit or comfortable to do it, but it is not very difficult. Simply what you have to do, suppose your lens is placed at 90 degree. So place the junction JCC, their minus number on the one side. If they keep minus marks of the JCC in clockwise direction near the handle. So on the basis on which, and flip it on the basis of that, they will tell. But for the doctors, it might be very difficult. So simply what you can do, you take the minus 0.5 cylinder and align the cylinder axis with the cylinder axis in the trial frame. If it improves, that means more power has to be increased, and go 45 degrees away from the axis on which direction it is showing improvement. You have to move the original cylinder on that direction. So by this way, it goes very fast. So instead of JCC, you can use cylinder in your hand and just align and move this way or that way. So by this way, you will know the proper cylinder power. And after adjustment in the cylinder, spherical equivalent is disturbed now. So you need fogging at this time. So simply add 0.75. If 6x6 is just readable with some blurring, then keep it the same. Otherwise, increase the size up to 6.9 or 6.12. So with 0.75 fogging, add minus till it is just clear. So now, instead of -1, now it is 0.75. After this, simple test is duochrome test. You have to remember RAM, red is better, add minus. If patient is saying the red is better than the green, so keep on adding minus. If they say green is better, then keep on adding plus. So by this way, you will refine you get the additional refinement. Duochrome is done, then this is most important thing, because this test is going to be done maybe for the whole life. So give some time to do binocular balancing. This is important to know that whether there is equal accommodative efforts in both eyes. Otherwise, patient will be always in discomfort. In binocular fogging, you have to open both eyes with final glasses and add +1 or 0.75 in both eyes. Both will be blurred, and ask which one is more blurred or which one is better. If they say the left is better, then add +0.25 more in that to make it that one more blurred, and find from where it becomes reverse. Suppose the left eye was better, or after adding +0.25, there will be a point when the other eye will become better than this, comparative. So by this way, you will know that which eye is accepting +0.25, add this +0.25 in that eye. Then ocular dominance has also a role. Suppose the right eye is dominant eye and the left eye is non-dominant eye, which is going to be used for the near works. In that eye, after the final refinement, add +0.25. That means make it little more myopic to non-dominant eye. What happens that after surgery by phakic IOL or by PRK or lenticule, any surgery, most of the time the patient say that distance is good, but near is difficult, because they are the myopic patients, and we try to correct almost full. So most of the time they say that near vision is not as good. So if you make the non-dominant eye slightly 0.25 myopic by adding plus 0.25 in the final reflection, that problem will be solved and patient will be very happy. And unless they check it one by one, they will not appreciate the difference. And the cycloplegic refraction to reaffirm the subjective refraction. If your refraction is matching with the cycloplegic refraction, then you don't need to call them for the post-pediatric test. In some cases, the gross difference, like there was accommodative spasm, so there could be a difference of 5 to 6 diopter. So it is better to repeat the refraction and call for the PMT. Thank you.
So thank you, sir, for this very small tips which are, I think, very important for doing refraction. I think all the ophthalmologists must give some time, especially in LASIK patients or Phakic patients, to counter check the power of the patient. So now I invite Dr. Dipesh, okay, then Dr. Anil Srivastav again for surgical burns in trans PRK.
So
Actually-
surface ablation is not new. It was started and was FDA approved long back. I am doing PRK since 2002 after mechanical removal of the epithelium, 2-step procedure. Not happy due to pain, slow recovery, inaccurate result. So I will not discuss about the science of the PRK, but share few personal experiences how to make it better. Smart pulse technology came with a promise to reduce residual roughness, better smoothness, and give a whole range of customization. It was surprise for me to see the final outcome, which was almost painless post-operative. Surface ablation was very smooth. So during surgery, during time out, when you are going to start the surgery and talk to the patient, reduce the patient anxiety, be gentle in putting the speculum, because this is the time when patient is most apprehensive. Dry corneal surface evenly. If you are in hurry and upper half is dried, lower half is wet, a patient has moved the eye and with the fluid in the cul-de-sac, it has been wet again. So that wet part will be undercorrected. So make sure that it is evenly dried. On an average 40-second procedure, ask the patient to be in statue, no movement in any part. I personally take 2 short breaks of 5 seconds to help in cooling and debris clearing. I use mitomycin C in every case. Irrigate thoroughly and put BCC. Irrigate under the BCC again and remove speculum and put ketoconazole eye drop. Inflammation in post-operative 3 months is the biggest enemy, and the second biggest enemy is the UV lights. So give prednisolone. I give prednisolone eye drop 2 hourly for 1 week, then loteprednol 4 times 1 month, then 2 times 2 months, then 1 time 3 months if no IOP rise. Preservative-free lubricant for 4 months. Ketorolac only 2 days. Earlier I used to give for 2 weeks, but I found that it hampers the healing. UV protective glasses for 4 months. In case of haze appearance, start prednisolone for 2 weeks. Usually it disappears, but in delayed cases, it might persist or take longer time. So be careful to see even traces of haze, restart the prednisolone. Vision is nearly 6/6, immediate and the next post-op. Slight drop from 3rd to 5th day. Satisfactory visual improvement by 7th day. After 2 weeks, there is no difference in visual outcome between trans-PRK and flap-based or lenticule-based surgery. So comfortable that I don't call them on next day, but I call them after 4 days to remove BCL. I tried some other BCL also. I have no financial interest, but I find that BCL from Johnson & Johnson is working very well. In some period of time, there was shortage of mitomycin C, so I thought that mitomycin C is not mandatory, so let us do it. So I did around 50 cases. So lot of cases came with the haze, and although we treated them, so what I feel that mitomycin C is very necessary in every case, whether it is a small power or the big power. So trans-PRK with the smart pulse technology, it is not the only trans-PRK. When it is added with the smart pulse technology, then it becomes a different technology. It's so good that I have stopped flap making by keratome or femtolaser since the end of 2018. It gives a little higher range of corrections without any tension of flap-related complications. Thank you. Yes.
Thank you, sir.
Yes, question, come.
Yes, sir.
With the mic.
Can you get the mic?
Come to this mic.
Very nice presentation, sir. You said that it takes 40 seconds. I think this is a standard for every diopter, 1 diopter, 5 diopter, or
Sometimes 30 seconds, sometimes 60 seconds. So most of the time, 4-5 for the 4-5 power,
okay.
it is 40 seconds.
Yeah. And the second thing is you said you take 5-second break and you clear the debris. That means
No, I
want to
just
understand
wait.
that.
I don't do anything. Just wait a short break.
That means you just take the foot from the pedal and wait, and then
Yes,
you again
yes,
start.
yeah.
Yeah, that is what I wanted to know. Because nowhere it is mentioned, because you said that debris clear. So
No,
put some
That will
drops
suck.
on.
The
It
debris
is
which
sucked
coming, it will suck
automatically.
in that
That
case.
plume is, no? That,
Yeah,
that
yes.
is already been seen.
Yeah. So, because if the heating is there,
Transfer.
Actually, it is, Dr. Vikas, it is recommended to wait because epithelium removal itself gives a lot of heat, creates heat on the corneal. And if you continue the procedure, so it will give more pain to the patient. So it's just wait for a few seconds so that your cornea cools down and then start your stromal removal.
out of 40 seconds, after 15 seconds, just a 5 second
Just
pause,
wait for some.
and then after 25 or 30 seconds, one more. That's it.
No, sir, there is a difference when we are doing with the Schwind versus alcohol. The basic difference is
Is it in a continuation?
Huh?
That is in a continuation.
no, that is a different thing. In Alcon, what it does, it firstly removes the epithelium and then it separates the stroma. In this Schwind, what is happens, it first goes inside. It's a transepithelial. So it goes inside, first removes the stroma and then it removes the epithelium. So it is slightly different. So in this case, the stroma is removed first, followed by the epithelium.
Yes.
So this is something which is very peculiar with this machine. Huh.
And epithelial thickness, as Dr. Dipesh expressed, it is very important, because if suppose the actual epithelium is 50 micron or 65 micron, and we have mentioned 55, So the stromal ablation will be lesser than the required.
We have not compared, but typically transepithelium is by Schwinn machine only.
Yeah. I compared means in one patient we did this, what the procedure name is, Alcon में नाम क्या होता है?
Apicultura.
No, not the epicondylar.
अच्छा.
Like
Soft
trans PRK we say na,
हाँ.
smart
Smart
surf
pulse,
we call
smart
in,
pulse technology,
नहीं,
SPT.
No, this is with the Emrys Schwinns. उसके साथ होता है,
उसका होता है.
I'm just forgetting the name. Actually, in which we first remove the epithelium and then we just wait for a few seconds and then we laser for the corrections, the stromal ablation. So we compared with the alcohol. So one eye we did with this machine and the second eye we compared with alcohol. So we found that alcohol, the patients with the eye with the alcohol being used, they were more comfortable. And the recovery was also more or less same, but they continuously, the patient complained that the pain is more in the eye where we use the laser. So might be the heat which is being created during the epithelial removal, that might be one reason. And second thing, you need to do the epithelial mapping before, if you are doing
Very
trans
important.
PRK regularly. Otherwise, sometime you will end up very irregular kind of.
Over and under
Up to one
correction.
diopter's change can be there.
Yeah.
If the epithelial mapping is not correct. हाँ. Remove the epithelium.
And now alcohol, may you can, I just modified my technique. We are not using any well to fill the well with the alcohol. We just keep the well there and we soak the marocil with the alcohol and just put it and just roll it for a couple of seconds and then remove it. Before taking the your well out, just push the water BSS so that
Doesn't
any
spill out.
amount of a drop of alcohol is there, that is being diluted. So it works very well.
Dr. Srivastava, there are two major concerns. One is the epithelial haze, which we have also seen in few patients. And it is, I think, one of the limiting factors for transepithelial PRK. And sometimes you don't know, in two patients, in one patient everything will be fine, in one patient the haze will be there. So it has something to do with the corneal biomechanics. How can you judge it any way that the patient is going to have haze, or can you prevent it from happening rather than using mitomycin C or something else?
I don't think practically anything can be done. So when we are treating smaller values up to 6-7 diopter, although you can treat even larger diopters, but most of the time there is a limiting factor of the keratometry. So usually we are limited to 6 diopter, but sometimes the pachymetry is very good, even 600, which can be treated up to 8 or 10 also. But the flat K is already 42. So if you treat 10 diopter, it will become around 32 diopter. So it will be so flat that the vision in your room will be 6/6, outside it will be 660. So the overall quality of vision will go very drastically abnormal when the flatter K becomes flatter than the 37 diopter. So I always keep 38 diopter cutoff for those who need precision. Maximum 37, 36 who don't need precision in their job. They just want to get rid of glasses and want to do executive work or the housework. But those who need precision, their flat K should not go below 38. So most of the time we are having 42 to 43 diopter of flat K preoperative. So we have limit of doing 4 to 6 diopter.
Can I add one thing?
Yeah.
So if your ablation is more than 70 microns, then chances are more. Second thing, if the patient has any rosacea or any keloid in the body, so we can directly ask, do you have any scar in your body where there is a keloid formation or hyperreactions? So those patients are prone for getting epithelial haze. And if your ablation is more than 70 micron, then again the chances would be more. That is why under 3 diopters of refractions, we normally don't put any mitomycin. But if you are dealing with the higher, correcting the higher powers, then you need to be very precise about the mitomycin application.
One more thing, you were telling that in every case you do 10 to 20 seconds of mitomycin C application. So even if it is 1 diopter, you do the same. Even if it is 6 diopter, you do the same.
Same, yeah.
Actually, what we have been taught that is around 8 seconds per diopter, something like that.
Yeah,
8 to 10 seconds, whatever it is.
What I feel that the work is done even in few seconds, even in 1 second.
yes.
Post-operative. No, no, not in the
No,
initial
no,
part,
the later
in the late
part.
phase.
Later.
So that is a major concern.
Scarring.
Huh. No, you are doing with the flap, na? Huh. Huh, huh. Huh. Huh, huh.
No,
Nidec.
even Nidec and Boss and Lom and now Swind.
And among all these machines, you think Schwind is the best in your hands? Schwind is the best.
I feel.
Because you have also been using Alcon also.
No, I have tried but not purchased. So I have used Boss and Lom and Nidec. And I have seen the results of the other machines, particularly for the trans PRK. Only Swind
It's better.
is giving a completely different result.
No, there is no problem with the result. There are only two things. One is pain, post-operative pain, and the second is haze in very few cases. So these are only the limiting factors.
For immediate pain, we give one bolus of intramuscular dexamethasone,
Okay.
hydrocortisone, sorry,
IM
IM,
or IV.
before surgery.
What do you
before
give?
surgery.
What do you give?
Dexamethasone,
Not the dexa, the hydrocortisone.
hydrocortisone.
So one bolus of hydrocortisone, 2 ml, before surgery. Patients are very comfortable.
Okay.
So you can try this also.
Injectable है बच्चा.
Thank you.
Thank you so much, sir. Now we invite Dr. Sudhir Srivastava for his next topic, and everyone knows Dr. Sudhir is a. You can take your
How
time.
much time is left?
Take 10 minutes. He will be speaking on Phakic IOLs.
Thank you, Anil sir, for having us here. Basically, it's your effort. And coming to trade one is just like going to Andaman from Delhi. So that is why the attendance is poor. Unfortunately, the session was excellent, very beautifully planned, and it has all material for regarding the. And one thing I want to add that the refraction is very important part of your because what you are correcting is the refractive error. So unless you know the proper refraction and because we are from the era where we used to do retinoscopy in each and every patients, we used to have refraction set postings in our departments, and autorev were not available that time. So still the retinoscope is always in my hand. That's my best friend. And before starting conversation with the patient, I always look the eye, the glow with the retinoscope. It gives lot of ideas. So today I'll be talking about the sizing and calculation of phakic IOL. And we all know that it has revolutionized the correction of higher myopia and the astigmatism, especially in the thin corneas, and the power is very high. And the visual quality depends not only on the correct power and the centration, but also on the vault. And vault is the gap between the back surface of lens and the anterior surface of the crystalline lens. So I am doing refractive surgeries for the last maybe 15 years and I started with the phakic, this Star Surgical IOL. And I'm using all variety of phakic IOLs available, so no financial disclosures involved here. But the most important thing for the phakic IOL is the size, because it matters, it is needed for the quality of vision. So good quality of vision, you need to have a good size of IOL, because it creates, reduces the chances of complications like glaucoma, cataract, or if you are putting toric IOLs, then decentration or unstable toric lens in the eye. So important thing is the the vault, which is the back surface of lens and the crystalline lens, and the ideal vault is around 250 to 750 microns, but we can go up to 100 to 1000 if the space is available, if the patient is not having any problem. So what kind of problem? If the vault is high, again because the lens is behind the iris, so there will be iris contact and pigment dispersion will be there. It can create pigment dispersion, glaucoma, angle closer glaucoma. And if the vault is less, then because of the contact, patient gets early cataract formation or decentration or a free floating toric lens. So when the vault is reliable, sorry. So it is, if you are implanting under BSS, then then within an hour you will get a proper, you can assess the vault as your corneal incisions are properly sealed. And if you are using viscoelastics, whether high viscosity or dispersive, it's again a point of debate which one is the better one. I prefer high viscosity viscoelastics. It takes around 3-4 days to to be fully drained out, and then you can assess the vault position. So many parameters we analyze for the phakic IOLs to achieve a best lens available to give the best satisfaction, and out of them the antechamber depth is the most important thing, and we use optical biometers, topographers for the assessment, and safe cutoff is 3 millimeter. We can go up to 2.7, even 2.6 sometime, very rarely, but 2.8 or 2.7 would be the general answer. Beyond antechamber depth, we need to see the angles for any pigments or pseudo exfoliation or any kind of inflammations or cysts. So you need to evaluate. And word about crystalline lens rise, because don't forget that lens is growing every years, it is growing in size, so it may affect the vault in future. So as Dr. Moria said, that still the white to white measurement is the best answer, because but ideally should be done under digital under the microscope in the supine position with the digital caliper, but it's not possible in a clinical practice that you can't bring your patient to the theater for the measurement, or you can't keep a microscope in the OPD. So we do it on the slit lamp. It's very comfortably we are doing it for the last so many years, and we are getting excellent results. You can trust on those things, validation you can do as Dr. Moria said, but no need to, you can't, this is not the answer, because in my right eye, Pentacan says 11.8 millimeter, IOLmaster says 12.1 millimeter, and I3C says 12.1 millimeter. So, and every time when you take the readings, you will get the variation. So it's not the final answer. Still the answer is the white to white with the digital caliper, but you need to learn the technique. And this is the best technique. So this is the technique where because caliper is very big in size, and if you are taking measurements on the slit lamp, so sometime patient because of the fear squeezes the eye. So just squint caliper you can use, take n number of readings and just give an impression on the thermal paper, and then on the thermal paper you can take the readings with the digital caliper. This is one way, and this is the most reliable way of taking white to white measurement. Now we can discuss that why not to put in sulcus to sulcus, because the lens is finally going in the sulcus, so we directly take the measurement, will get the answer, yes. Studies have already proven that if we trust on sulcus to sulcus, we'll get the best vault. But measurement is difficult, and as it's not practical, as Dr. Moria said, and there is a poor correlation between STS and white to white. And even with the UBM, you will get a variable readings with the different, examiners. So again, STS is not a trustable thing, although study says that, say, if you are able to take it, then you can trust on, but white to white measurement, properly taken white to white is the still answer. But what if the white to white is 11.7 and 12.2, but the company says you need to put one lens for this different powers, different sizes. So if the space is less, again you will get a higher vault. If a space is bigger, then you will get a flat vault. So you have to be, clinically you have to be capable if the antechamber space is there. then you can go with the higher vault. If the chamber space is less, then you can go with the lower vault. But for the toric, you need to go with a higher size because we don't want any free floating toric lens in the antechamber. Obviously, loading is difficult, different with the different companies. IPCL, it's the same butterfly cartridge which we use for IOL, normal IOL implantation, and always mix with viscoelastics with BSS. And the ICL is slightly tricky because here you need to put a lens with the in the cartridge and snugly just fit in the grooves, and then you need to pull it in the nose of the tip. So it comes with the practice, and now the biotech comes with the preloaded lenses. So again, it's a learning curve and you can learn. So word about phakic IOL. Phakic IOL is it's a very rare deed because in hyperopic eyes of the chamber depth is obviously we get a lower antechamber depth. The size of the globe is slightly smaller, and for phakic IOL, you need to have at least 3 mm of antechamber space available, and you need to do PI on spot or in the pre-op because there is no central hole present on the phakic IOLs. So, word about the dynamic vault change. When you do the dynamic OCT, with the size change in the variation of the pupil size, you will get a change in the vault. Sometime when you examine on slit lamp, you see that the vault is okay, but still the patient is getting early cataract changes. So if you take this patient on OCT and you put through a light, then you can see that there is a vault change with the size of the pupil. And word about the prediction formulas, now these are coming in a way, and AI is being involved because there is a crystalline lens rise, so we need to predict that, and in future we can predict how much of the vault we are going to get after 5 years or 10 years down the line. So take home messages, ideal vault is 250 to 750 microns. Learn to take the white to white measurements, very, very important thing. Antechamber depth measurement is the most important thing. Evaluate, you can use UBM and OCT, just make it practice so that you can be well versed with these tools in future. Check vault every follow up, and maybe in future with AI and with experience we can have a better prediction of ideal vault. Thank you.
Thank you so much, Dr. Sudhir. So one question is, have you inserted IPCL or ICL under fluid, in fluid?
Yeah.
And it is perfectly fine, no problem with this.
You have to be
Because
slightly.
there's a chance of touching the
Yes,
lens.
yes. When I started it in one patient it came with the sudden surprise of touch of capsule. Fortunately, there was no puncture. So you have to be very cautious and selective. Especially your keratome should be always fresh. Don't use used keratomes because sometime it can suddenly enter. And second thing, if you are not comfortable, just put some amount of viscoelastic in it. It is not, we are not going to, someone is not going to grab your collar, why you have implanted under the, so you can mix and match and you can learn, and future, even you can practice it in your cataract patient, how to create side port incisions and clear corneal incision without putting viscoelastic in the
So
incision.
in cataract, we routinely do
The same way you can do.
Here the only issue is because the lens is there, so when you are putting the lens behind it, so there is a possibility the lens touches there and the later cataract.
Sometimes it gives lot of pain to the patient also. So just put viscoelastic.
It is sure that viscoelastic gives safety, additional safety of slow releasing and not hitting anything, and a good control of the chamber. So my understanding is that visco, at least for the phakic lenses, visco is a better option. And for IOL also, when the IOL is not very friendly, there are some lenses who are very stiff, like bottom lens lenses, and there are many other lenses with different designs. So any hydrophobic lens with extra design, extra stiffness, again, if you are trying on the hydro, so many times it will slip during insertion, or even it goes with the jerk, so it might tear the posterior capsule. So all the hydrophilic lenses are very good. You can push it this way, that way, it will go into the bag. But hydrophobic lenses with a thicker and stiffer in nature, you should be careful while putting under fluid. Yes.
You are talking about the hyperopic phakic IOL. I did an IPCL plus 16 diopter. ACD was fine, 310 like that internal, and I did the PI and
Surgical PI or laser PI? Surgical.
With the halo vitrectomy I did use.
Yes.
So postoperatively, when I see the patient, patient was fine. Vault was also fine. Once I saw there is a optic catch.
Yes, it happens.
But patient removed his head, and again when he put it, people slightly dilate and constrict. It was gone. Then it was not there anymore. But I was apprehended in the third month of visit. I saw some pigments. So what should I be cautious about the next visit?
Pigments on the lens?
Not very much, but some pigments, Irish pigments were there in the lens.
Regarding the phakic IOL, you have to be very cautious. Size, as you said, that it should be always more than 3 millimeter, and
Vault
always
was
do
about 600.
1 PI, or maybe you can do 2 PIs sometime, because sometime your lens optic can block your 1 PI, so you can do 2 PIs separate in areas, so that you will get a better fluid flow. And second thing is you can get sometime the capture that you said, because of this the slightly semi-dilated pupil, and in those patients, if the patient is having semi-dilated pupil and this capture is there, just dilute the pilocarpine and give it for a few weeks to the patient, and just tell that if you put it, you'll feel some heaviness and discomfort, but glare, and this will go on. So maybe
I did the same thing for 1 month.
it works.
Okay. Should
And-
I continue this or?
No, you can stop it after 4-5 weeks time, and then always check the angles, and always check the disc evaluation frequently, and obviously the intraocular pressure.
What was the power you used in the hyperopic IPCL? Plus 16. I also used plus 15.5 just 1 month back. And what I was told, because the anterior chamber depth was very good, I didn't buy both eyes. I made 2 PIs, but patient is doing perfectly fine. So it was
they made me sign another
yes.
document.
I had to sign another document for that.
Cautious.
No, but patient was doing fine, and as per the records, there has been no literature which says 15.5 or 16, because the anterior chamber depth was 3.73 in that patient somehow. Yes. No. They don't want hyperopic only.
2.7 depth for, or 2.8 depth for myopia. So you said 2.7 can be taken, but because many a times we are stuck, it is 2.75, 2.73, 2.8. But my question is whether, suppose there is -5, one is -10. So would you go with the same 2.7 is there, and somebody is coming with -5? So because the periphery of the lens, that means little bit lesser, thicker than -10. So what is your take? Suppose -10 and -5, 2.7. You recommend both in -5 and -10. Okay, you can go with 2.7 depth.
My intent of saying 2.6 is, normally we don't do this. 2.8 is the cutoff,
Cutoff is the
but sometime suppose the powers are very high, and the person is quite young and not fit for clear lens extraction, or obviously refractive procedures, then in that cases, with the caution, you can implant a lens,
caution
and if you think that the space is less, then do a small PI.
PI, even in myopia.
And never don't try to do YAG laser PI in such cases, because YAG laser, the pigment dispersion will be there, and that pigments will occlude the angles. So it will again compromise your angle. So always do a clean cut surgical PI.
Although the cutoff is 2.8,
Yes.
but I have done around more than 20 cases between 2.7 and 2.8.
Yeah.
And actually this problem was when the center hole was not there. So after center hole has come, I have not seen any case of glaucoma or
Yes.
other problem. So after Sentinel, I think 2.7 is safe enough. That's my personal
No, definitely
feeling.
2.7 you can do. You have to just go do a gonioscopy,
Huh.
and angles are good open. Then I think it can be done.
Yes.
Yes.
Additionally, you can check the pre-operative lens rise on our OCT. The lens rise is very convex. Then again, you need a larger AC depth. And if the lens rise is moderate, then you can try this 2.75. If already pre-existing convex lens rise, then try to avoid.
Very basic question, how to see the lens rise, just
Slit.
please elaborate.
On the OCT anterior segment imaging, and see the level from angle to angle. If it, how much it's crossing, 200, 300, 400. So up to 250 is good enough. More than 250 micron is rises higher. So you have to achieve a higher wall here. Otherwise it will touch, at least in the periphery it will touch. Yeah. So only 10 minutes are left and 2 speakers are there.
So thank you so
Thank you,
much,
Dr.
sir.
Sudhir.
So thank you so much, and it was really a very good interactive discussion. And the next is by Dr. Navendu Rai, who is a prolific cataract surgeon also, and he would be speaking on complications and enhancements in both modalities.
Yeah, thank you, Vats. And thank you, Arun sir, for giving this opportunity. Most of the topics are already covered by the previous speakers, so I'll just enumerate them. So this introduction is not required. Yeah, early complications of surface application. The most common are pain and discomfort, which is significant for the first 48 to 72 hours due to large epithelial defect. Delayed epithelial healing can lead to increased risk of infection and sterile infiltrates. Corneal inflates could be sterile or infectious. Late complications, we can have corneal haze, which was discussed in detail previously, and the cause could be subepithelial fibroblastic activity. Prevention, we use mitomycin C during surgery and UV protection post-op. Regression, the gradual loss of refractive error over time. Dry eye syndrome is not that common as it is with the flap procedures, but it still can be there because due to nerve plexus disruption. Managing surface ablation complications, the corneal haze can be the prophylaxis. We use intraoperative mitomycin C 0.02% for 15 to 60 seconds. Treatment, intensive topical steroids, which has to be tapered slowly, and oral vitamin C might help. Persistent epithelial defect, we use preservative-free lubricants frequently. Then a bandage top contact lens or autologous serum drops can be used. Microbial keratitis requires immediate and very aggressive management, and immediate scraping for culture. Aggressive hourly fortified antibiotics, Vanco or toromycin can be used. Sterile infiltrates, increase the frequency of topical steroids and rule out the infection first. And if there is any sign or there is a chances of infection, do treat it as infective keratitis. Phakic IOLs, the immediate and early phakic IOL complications are acute pressure spikes, often due to retained viscoelastic material or pupillary block. Toxic anterior segment syndrome, which is non-infectious inflammatory reaction to contaminants. Endophthalmitis, extremely rare but the most feared complications of any intraocular procedure. And sizing issues, too large, high vaulting causing angular glaucoma, or too small, low vaulting leading to contact with the natural lens leading to cataract formation. Long-term complications are cataract formation, endothelial cell loss, pigment dispersion syndrome, and chronic uveitis. So managing acute IOP spike or pupillary block, which is medically by topical or oral aqueous suppressants. Surgically by burping the incision to release trapped viscoelastic or performing a laser PI if not already done. Sizing issues, the wall problem, if high wall, more than 750 microns, if causing angle closure, the lens must be exchanged for a smaller size. If there is low vault, less than 250 microns, if touching the crystalline lens, the exchange for a larger size to prevent cataract is to be done. TAS, intensive topical steroids every 30 minutes to control inflammation quickly. Cataract formation, then you require IOL implantation combined with standard phacoemulsification and replacement with a traditional IOL. Endothelial cell loss, regular spectral microscopy in such patients is to be done every 6 to 12 months. If cells count drops below 2000 cells per square millimeter or shows a more than 10% annual drop, explantation of the phakic IOL is mandatory. Pigment dispersion, glaucoma, if medical management fails to control IOP, the lens should be removed. Decentration, surgical repositioning or exchange if causing significant visual loss or halos has to be done. So a comparative risk table, primary site in surface ablation is corneal surface, while in phakic IOL it is intraocular. Main risk is haze or infection in the surface ablation group and cataract or enthelial formation or enthelial loss in the phakic IOL group. Pain level is usually high in surface ablation and minimal in the phakic IOL. Reversibility, the procedure is irreversible in surface ablation while it is reversible by explantation. And vision threat is by corneal scarring in surface ablation, in ophthalmitis or glaucoma in the phakic IOL group. The surface ablation complications are mostly related to healing and haze, while phakic IOL complications are related to space, sizing and intraocular health. Thank you.
Thank you, Dr. Navindo. And now the last speaker is Dr. Abhishek Chandra. He is Secretary of EPSS, and we are very proud that he is competent and expert surgeon in surface ablation and phakic IOL both.
No problem.
So we are going to put some questions. All the audience are, please ask your questions and doubts. He is competent to answer. So my first question is, your experiences treating hypermetropia with phakic IOL and surface ablation. What are the precautions and what are the possible challenges?
Okay. So if you're treating hyperopia with IPCL or ICL, so one is sizing is very important. The second is anterior chamber depth is very important, because already usually the anterior chamber is compromised in hyperopic patients, and if you don't take care of the anterior chamber angle, you can land up in glaucoma or lens touch. So you have to take that into consideration. And another important thing with hypermetropia is that you have to make PI, usually 2 PI and not 1, because as you told that if the one haptic of the IPCL blocks the PI, you have another PI which is open up. And this has to be always surgical with around 1 mm of clear opening of the PI. So that is very important. The basic concept is when you are doing a myopic IPCL, the center part of the lens is very thin because it's a concave lens. When it is a hyperopic, then it has a convex lens. So in a myopic patient, since the center part is very thin, the hole is very small, and if it is a hyperopic lens, then the hole will be like a tube. So if you go by the principles of physics, if the hole is in length, then the diversion of the rays will be much more as compared when the length of the hole is very small. So in hyperopic patient, that is why we don't have holes in hyperopic IPCL. So you have to do a PI, that is mandatory. And when you are doing a surface ablation, one thing which I have found that if there is astigmatism associated with hyperopia, it is better to do a LASIK than a PRK. That's my personal thing. Yes, sir.
Anil sir, can I add one thing regarding the, as Abhishek very rightly said, that don't ever try hyperopic correction with epi procedures, because in hyperopic corrections we ablate at the periphery, and in myopic corrections we ablate at the center. So if you ablate on the peripheral area, so there will be a gutter, and the epithelium, when it starts growing, it will fill the gap, and again you will come back with a regression. So regression would be more, and again the chances would be more for the haze. So it is as very rightly said that always lift a flap and then do hyperopic correction.
But in small amount of hyperopia, 1 to 2 diopters you can do. That actually doesn't cause much problem. But if it is a large hyperopia, 4 or 5 diopters, then you have to be very.
We always explain in the hyperopic patient that the regression would be there because there would be leftover in your eye. And
Actually,
again, if we correct on the 0.5, 0.75 on the cornea,
many times these patients are those who are coming for either for marriage or for this government job or something. In that they want for some time it is there and then it is.
So regression would be there.
Yes. Thank you so much, sir.
I also have similar experience that in hyperopia, even with 1.5 diopter, the predictability is not as good. Predictability regarding that whether there will be haze or not. Mostly there is a small amount of haze, even up to 1.5 diopter. And in IPCL or ICL, most of the time, the AC depth in hyperopic patients is limiting factor. Most of the time, they don't permit any intraocular lens. So in those cases, you go for the clear lens.
Clear
Where-
lens extraction.
Because most of the hyperopic patients are having a smaller AC depth.
Actually, there was a recent very good pre-leg studies in which they have done around 200 cases in which they have removed the clear lens and did in a normal presbyopic patient. So that will also depend upon the age of presentation and the anterior chamber depth and what the patient wants. Now let's suppose there is a 20-year girl with 5 diopters of hyperopia and she definitely wants to remove her glasses. Then we will go for a clear lens extraction with a multifocal IOL. We have been doing that. But you have to be little cautious and you have to explain everything to the patient that there is a slight risk involved in every surgical procedure. And this is something, for example, I have seen many hospitals, especially the newer coming corporate hospitals, they tell every time that catheter is 100% safe surgery and there are no complications, everything will be fine. So don't commit such things to your patient. You can say it's a very safe surgery, the chances of complication are less than 1%, that is true, but don't say it is 100% safe surgery, otherwise you will end up in trouble, whether it is IPCL, catheter surgery or any other surgery. You have to be...
Thank you,
you have
Dr.
to-
Abhishek. Time is over.
Yes,
So let's assemble here for a photograph.
Okay, thank you so much, sir. Thanks.